All right. Hey, everybody. I'm going to start sharing my screen here and we'll get going. I'll introduce myself and Dr. Kaler here. I'm Dusty Roder. I'm one of the founders of a company called Cowork Health. Cowork, we're essentially a portal and a billing system to help with your Occ Med, your EPS, billing, communication, account management. You can check us out at coworkhealth.io. And then Dr. Kaler, what he's currently doing is he built and is running a company called Occ which helps guide providers through work comp and Occ Med procedures to make sure you're able to accomplish those in your clinics. But I'm going to give you a little bit deeper dive into Dr. Kaler because he's going to be delivering most of the content today. We will do live Q&A at the end as well. So feel free to use the chat or the Q&A button within Zoom to ask those, and we'll make sure to answer those either as we get going in real time or at the end for sure. So Dr. Kaler, he is board certified in occupational medicine. He has over 40 years in the urgent care Occ Med business. Where he started, he founded a large urgent care group where he was one of the pioneers of the urgent care and Occ Med hybrid model. He was able to grow that group to 56 clinics and more than 10,000 Occ Med clients when he left there in 2022. Since then, as I mentioned, he founded Occ and is focused on helping urgent care clinics keep work-related injury care visits in their clinic. So Dr. Kaler, with that said, I'm going to hand it over to you.
Great. Thanks, Dusty. Appreciate it. So just by way of a little bit of background, Dusty already mentioned I've been around for 40 years, which is where I got my gray hair. But actually started when I was 29 years old. And back then, our first physician, we paid $35 an hour and our visit fee was $28. So there's been a lot of inflation. But if you look at that metric where a doctor visit and a 1 hour of doctor wages are close to the same price, and that's kind of where it's at now. There's a lot of, standard E&M codes, $125, case rate, $125, providers, physicians making $125, which is obviously why one of the reasons that the APPs have now become the primary providers. It's part of its economic, part of its lack of availability of physicians. But we've come a long way, and I've witnessed all of it over the years. Next slide. So we're facing a lot of problems right now in the industry. We're challenged. It's not a secret. It's not lost on you at all. Issues related to saturation of clinics because there was a windfall with COVID-19. A lot of clinics got built because of that, as well as the revenue capture by moving to APPs instead of physicians. There was a lot of upside 15 years ago, starting about 15 years all the way through COVID. And now we're facing clinics on so many street corners around saturation, basically. We have wage inflation, which is inexorable. We can't get away from it. The demand for the clinics obviously is high in every employee class in an urgent care clinic. Reimbursements are static, which is exceptionally unfortunate, but it's a function of the saturation. Obviously, the insurance carriers are not motivated to help us out in the least. Okay, if they can get enough urgent cares in an area, they're satisfied. There's been some groups that have been able to differentiate themselves in the marketplace to get higher reimbursement. I know our group was able to get an increase, a 10% increase from both Blue Cross Blue Shield and United Healthcare because we proved our CPT codes. We were doing high acuity, or I should say the same acuity we've always done, but it differentiates us in the marketplace from others. And that enabled us to get a reimbursement increase because you really have to prove value if you want an increase. And one of the ways to do that is show that, hey, we do high acuity, we do shoulder, reductions, we sew lacerations, we treat eye injuries, we take foreign bodies off the cornea, we treat minor fractures and things like that. So ER and specialty diversion is kind of their language because they know they have to pay more for that. But nevertheless, that's a challenge because you have to work to get that. There's no, inflation adjustment every year type thing, unfortunately. Acuity degradation, mentioned that already a little bit, that Unfortunately, we are referring a lot more, especially asterisk on injury care. Okay, we're good at illnesses, relatively good at illnesses, but with injuries, we have really, really dropped the ball over the last 5 to 8 years. That is accelerating. Actually, it's not plateaued at all because I used to talk about the big three, which are minor fractures, fingertip injuries, and eye injuries, and now I'm having to add a fourth one, which is lacerations. They're actually referring lacerations to the ER, well, for a variety of reasons, like we're too busy right now, I'm uncomfortable with this laceration, or whatever it might be. Next challenge is case rate contracting. This is the kiss of death. We never did it. Not once did we do case rate contracting in 40 years. Um, we wouldn't do it because we knew that was the kiss of financial death. And I know many are in that zone, and that's okay, but you're going to have to adapt, which is part of what I'm going to be talking about today. But that is devastating because it takes away x-ray reimbursement, takes away procedure reimbursement, takes away global fees for like fracture care and things like that. They're really high ticket items. It's catastrophic, in my opinion, because we were 40% occupational medicine, and we did a lot of injury care, both urgent care and work comp. And to do case rate contracting would have been devastating financially. Billing inefficiencies. I'm starting to hear a lot about that. A lot of issues on billing problems, bills, whatever, what old permutations of billing inefficiencies are out there. And then, of course, the perennial EHR struggles, like who likes their EHR? So that's been another challenge for many, many groups, is getting an EHR that will get them the reports they need, the functionality they need, the responsiveness they need. Next slide. So how did they respond? For by and large, the urgent care groups around the country responding with technology, getting things like self-registration technology, certain post-visit feedback technology, other things like that to help work around their EHR situation. They're looking to have greater throughput, faster, more volume, those kind of things, which if you're too focused on that, that's a problem. Then the EHR workarounds and replacements, people are responding by changing EHRs to a different company or getting workarounds and replacements for certain segments of the EHR they have. So even, for example, with Dusty with CoWork, he's part of that, providing an excellent back-end management system for workers' comp injury and EPS visits for workers' comp and Occ Med. So he's doing a great job because the EHRs did not provide that level of assistance that is needed to run an efficient Occ Med business. Sometimes they respond with more sites, let's get more scale. And then we've seen some groups like MedExpress got way out over their skis, too many clinics, they imploded basically. So that can be dangerous, but obviously scale does help you respond to cost pressures and those kind of things. If you can really scale effectively, that is spreading administrative and leadership folks across more clinics so that your clinics themselves can run lean and mean with a minimum, or I would say a very highly functional administrative staff related to running those clinics. So that's another. Then occupational medicine, of course, this is a hot one. A lot of folks want to get into that. I'm 100% supportive of that because that's what I did to survive and be successful. I was actually going broke at the beginning of physicians immediate care that I started. We were a year in and we were still losing a lot of money. And fortunately, someone tipped me off about doing occupational medicine. So I turned into basically a sales banshee on Occ Med, which saved the day for us from our challenges back then. And they can still save the day for you as well. Next slide. So what's the elephant in the room? Okay, so all the hand wringing and all the frustration related to reimbursement, related to wage inflation, all these problems, staff availability. The elephant still is provider performance because you can't lose track of that. All the money runs through the providers. Power of the pen, okay? They do the evaluations. They make the diagnosis. They do the coding or the elements that relate to the coding, and they do the procedures, which result in global fees and higher reimbursement, et cetera. And for patient satisfaction, obviously, is critical there. And there's a lot of groups out there that do a great job with patient satisfaction. It's important to keep in mind, though, on workers' comp, patient satisfaction is a bit of a different paradigm because you could have a skewed answer set on certain Occ Med patients who might not be satisfied, not because of the bedside manner of the provider, but because they were sent back to work and they wanted time off or whatever it might be, a narcotic or whatever. Patient satisfaction would be primarily related to the urgent care patients. Productivity, a lot of issues around that. Okay, talking about how many visits per hour. Well, in terms of the elephant in the room, so to speak, that high performance providers can see a lot more per hour. So the equation becomes, do we incentivize productivity or do we pay more to recruit more productive providers? And then on procedures, do we compensate them for doing the procedures? Because right now, basically, I'm generalizing here. I'm not out to criticize anybody specifically. I'm not trying to be overly negative. I'm just trying to state a fact that procedures are falling off the cliff at urgent cares. And this started again like 8 years ago or so. We did a big study from a really large EHR company who looked at the data and demonstrated objectively that procedure codes were falling off the cliff as far as billing goes. And so obviously if you're not billing for it, the likely is you aren't doing them either. So the idea that we've got to get procedures back into urgent care clinics, and then we got to stop the unnecessary referrals. And so all of this relates to provider performance, which is absolutely essential that you basically have to know everything there is to know about your providers. And then you got to figure out, what are we going to do to enhance provider performance? And it absolutely must include compensation. Well, unfortunately, with the advent of provider shortages, that providers know that they're kind of in the catbird seat, and I don't blame them at all. I'm not criticizing, don't blame them all. They know they're in the catbird seat, and if they push back, they usually get their way. And so that's really, really a problem. It's incumbent upon the clinics to solve this problem. Yeah, I use two different metaphors over the years for what urgent care operators are like. One is they're like coyotes, because coyotes can adapt to anything, any environment. We got coyotes living in the mountains and coyotes living in cities. Okay, they can live anywhere. And so we need to be able to adapt to the environment. And the environment from 40 years ago is drastically different than now, but it doesn't mean those challenges can't be met with creative solutions and great leadership type solutions. The second metaphor is unlocking a state, the combination lock, where you have to do the right combination. You can't just kind of blurt out orders and throw one against the wall and open sticks. You have to really get really deep inside the mind of a provider and understand how providers think, what they're interested in, what they want, things like lifestyle issues. It's just crazy how some groups require their providers to work every other weekend. I mean, that's intolerable for keeping a provider long term. These are young folks that lifestyle really may have children, and they might not even be the main breadwinner of their family. And so you don't want them going off to dermatology to get banker's hours or off to these other specialties, which they do. That does happen. And I'm sure everyone on this call knows about that. But, figure out a way to close on Sunday or something like that, or reduce your weekend hours, or do regional Sunday coverage where you have a regional clinic in an area communicated really well. And that's the only, one of 3 clinics that's open on Sunday in a certain area is genius. Okay. I'm telling you, that's genius. You don't make much money on Sundays anyway, but to be able to recruit providers and talk about you're not working every other weekend is magical. Okay. Next slide. Okay. So bonus systems, you got to pay more to get one. Okay. I alluded to that already, but you've got to really figure this out, because I feel that, in fact, I just tell you our case, I had some physician assistants making an extra $3,000 per month working for me with our bonus system that was highly skewed towards procedures. Okay. That's corneal foreign body removals, laceration repairs, fracture care, dislocation reduction, incision and drainage of an abscess, fingertips with nail bed repairs, things like that. And they loved it. And we had providers coming to me saying, "Hey, Dr. Keeler, I want to work for you. I want to work for your clinic because I heard you guys can do things that where I'm at now, they won't let me do anything." Well, part of that was because part of it, and I'm saying all of it, part of it was that whoever was in charge wanted those referrals to go to specialists because there's higher reimbursement. If it's a health system, they tend to want things going to the specialist earlier and more often, so to speak, because they want to monetize it effectively. Now, I'm not trying to criticize health systems, I'm just saying the realities of medicine or, how everyone wants to make money and you got to protect your turf, right? And so they came to us because they could do procedures at our clinics and we actually paid bonus for it. So you got to pay more to get more. So I think that you need to attack bonus systems, not wage increases. You should set your wages at least the market, if not a little bit higher, but bonus on top of that. You've got to bonus, and the bonus needs to come in a separate check, no more infrequently than once a month. So because if you make it quarterly, it won't work. It will not work well. Quarterly will not work. It's too long to wait. Everybody wants the money now. I'm not saying they're greedy. I'm just saying that's psychology. They studied. This has really, really been studied. Any bonus system has to be paid as soon after the activity as possible. So if you pay monthly and you pay based on CPT codes, procedures, you're already well into collecting that money before you bonus it out. So you are, the $3,000 a month that those PAs got that were on that bonus system and were very successful at it, they stayed with me for 25, 30 years. I mean, they loved working at Physicians Immediate Care and they were doing all these procedures and they weren't complaining about it. They weren't talking about how they're uncomfortable with it. They talk about being sued for it. They really engaged. And so you have to work the combination lock on providers to get them really happy because they work better too. And they see more patients because the more they see, the more compensation they get. Next slide. Okay. So part of this issue I want to address is medical leadership. Okay. I've been all over the country meeting with lots of groups. I know a lot about many, many groups in the industry at large. And there's medical directors out there. And again, I'm not trying to overly criticize here, but some of them don't want to suture. And when they don't want to suture themselves, or they don't know how to, or they're not comfortable suturing, are they really going to teach the APPs working under them to do it? Probably not. And the case in point really happened recently where there was a group where the medical director didn't want to spend money to have the ERPAs do the, ostensibly didn't want to spend the money to have the ERPAs do the laceration training because that particular medical director wasn't comfortable with suture repair themselves. So that's catastrophic. I can't stress that enough. You've got to have medical leaders that are 100% engaged. They need to be energetic, rock and roll. Let's do it. We got to do these procedures because that's how clinics are profitable in today's current environment. I'm proffering to say this to everybody, that as I look at this environment, I've been around a long time and I've been through the ups and the downs and seen many things, many different groups. Some made it, some didn't make it, etc. And in the current environment, it would scare me absolutely to death in urgent care in the current environment with providers who are quote unquote uncomfortable treating the big four I just mentioned on injury care. I would be petrified because back in the day, actually, they said, hey, Dr. Kim, you should get into Walmart. You should do Walmarts. I mean, you'll get in there. I could have had a meeting, could have had probably contracts for 20 Walmarts, 50 Walmarts, who knows? And I said, you know what? I don't get it. I can't put a provider, I can't spend the resource of a provider in a clinic where I don't have x-ray and I can't do procedures, can't do laceration repairs, can't do, these things in a little micro clinic in a Walmart. I never did it. And thank goodness I didn't, because it would have been a huge waste of resources, because those clinics never worked out in any reasonable way, profitability wise, because you want side contribution to be at least 15 to 20% profit in each of your boxes. And then you have administrative overlay on top of that, pulls out another, 5% maybe. So you have to be profitable at 10 to 15% to be successful and to be able to expand and grow organically, et cetera. And so, anyway, it would scare me to death to have a clinic without doing these wonderful high compensation procedures. I have 4 pages of CPT codes right here in front of me, and it's on the Occ website under CPT and Quick Check. And I've got the CPT codes, 4 pages worth of urgent care, Occ Med, injury care, relevant CPT codes. And I've got it right here, and it's available. And if anybody on this call wants it, I'll get it to you. Just ping me later, jkaylormd@occ1.com, and I'll get it to you. But the leadership, these medical leaders, you're paying these medical directors a lot of money because, that's what you do, right? That's what they get paid a lot. So if they're not training on a regular basis, the APPs you have on staff on a regular basis on lacerations, fingertip injuries, eye injuries, simple fracture care, splinting, casting, how to put a boot on, how to put a back support on, all those kind of things related to injury care, they're not worth their salary. I'm sorry, they're not. Because what are they? If they're not doing that, then what are they doing? If they're just pushing paper, and there's paper that needs to be pushed because there's certain regulatory requirements regarding chart reviews and those kind of things. But from medical leader, if you have a leader, a doctor leader, a physician leader, that has to include robust injury care, procedure training. There's no reason you can't get by pig's feet in the grocery store, put a cut on that pig's foot and suture it with 5/0 nylon and do running horizontal mattress. Okay. I heard a story about, they'd say, well, it takes me, providers were saying it takes us, too much time to sew lacerations. We could see 3 sore throats or otitis media, 3 patients in the time it takes to sew 1 cut. And they're like saying, oh, okay, well, if you're really busy like that, then you have to send them to the ER. So they're trading 3 of those simple urgent care visits for 1 really juicy laceration, sending it to the ER. The answer is not send it to the ER. The answer is sew faster. Oh my gosh. See, that's the difference between someone who's really been in the environment and had to scratch and claw to make money and survive, and someone who's in some kind of ivory tower administrative position who thinks, oh yeah, 3 patients versus 1, send them to the ER. That's absolutely upside down wrong. The answer is learn to sew faster. Running horizontal mattress suture. I have a video on Occ1. I'm sewing a 4-inch pig's foot laceration with the camera right on top of it in under 4 minutes. Okay. 4 inches in 4 minutes. And I proved it. You can do it. And you can put a stopwatch on the video if you want. It can be done, and it's not, practice makes perfect. Some of my best suturing providers all these years were PAs. The very best, some of them were as good as anybody. They're as good as I am. Okay. And suturing. Okay. So please have your medical leadership. They have to upgrade. Otherwise, you're better looking somewhere else and making it, investing that money in some other area. Okay, next slide. So you have to invest in the right equipment to do procedures. Okay, you've got to have some sort of either a head-mounted magnification or slit lamps to do eye injury care, and you must absolutely do eye injury care. There are so many corneal foreign bodies coming in from all manner of employers all over America. You've got to be able to do that. It's a travesty to refer an eye injury to an ophthalmologist to just take a foreign body off the cornea. And somebody might say, sort of like the righteousness syndrome, where they say something like, well, they really need to go to the highest level of care. Well, the highest level of care for anything that I guess would be a super specialist somewhere, but that's not why they came to your clinic. They could have gone to a specialist. They come to urgent care. They want fast treatment. They just want the cornea, foreign body lifted off the cornea. If you send them to ophthalmology, here's a phone number for an eye doctor. Do you think they're going to get in anytime soon? Do you think their phone will actually be tied to the phone? What if the office is closed and the foreign body stays on their cornea for 3 days? It's really, really, to me, upside down to say the best destination of care for an eye injury is an ophthalmologist when it isn't. It's you in the urgent care center. You are the best person because what they need it to be done is to take it off. It's not a specialized procedure. It's not a corneal transplant. It's a simply lift it off with a metallic spud. It's dull. It's a scoop, like a scoop. You just lift it right off. Easiest procedure ever. Okay. Other equipment would be to do occupational medicine, pulmonary function testing equipment. You need an X-ray machine. You need a trauma room where you have a Mayo stand and good lighting for doing procedures. You need to have DME with boots, back supports, Futura splints, tennis elbow straps, arm slings. All that stuff is highly monetizable. You've got to do it. You've got to do injuries to survive. Okay. Then you have to invest, again, I already mentioned wages, a good wage, and then bonus on top of that. They'll never leave you. Talking about golden handcuffs. If a PA is making $1,000 a month, which is $12,000 a year, not that much money, okay, then that's like an extra, a bass boat, a car payment, a bigger house. I mean, seriously, $1,000 a month is real money, and you're going to get all of that and more back with the procedures they do. Next slide. Okay, so this is one way to kind of unlock the safe and get to where you can optimize your business with providers. I mentioned the CPT code. So I have 4 pages of CPT codes. If you want, I can give it to you. What you really, and I have the reimbursement from North Carolina. I'm working on getting Texas, but these are hundreds of dollars in these procedures. Each procedure could be $100. That's a lot of compensation for doing something. Like in the case of a corneal foreign body, you have to examine the cornea anyway, and you're already there. Why not lift it off while you're there? It's not extra time. You just do the procedure, and you get the E&M code plus the CPT code for it. Okay, so you rank your providers on CPT codes, and you can break out lacerations from fractures from eye injuries, and then rank your providers from top to bottom based on how many, for example, eye injury CPT codes did they document or perform in 40 hours. And if that number comes in real low, then you multiply it by 100. Okay. Then you get a number that has an integer at least. Okay. So you might rank them. You might find the range would go from, let's say, 75 down to 16. And you'll find the variance will be dramatic. Okay. Because you'll have high performers and low performers on CPT codes. And that's a message. And this is why it's an elephant in the room. Like, we're striving to get higher reimbursement from United Healthcare, BCBS, workers' comp, whatever. And right here in front of you is higher reimbursement by lifting a corneal foreign body off the cornea. That's your fee increase. Okay. Or get this, putting a boot on a distal fibula avulsion fracture, which is no more serious than an ankle sprain, and get paid $800 to put a boot on it and get the global fee for the fracture and see the patient back. It's that simple, $800. And we're talking about higher reimbursement. We just got $800 more for that case. Well, wow, that's good. Okay. I mean, I hope this gets your attention because it's a gold mine. It's you just, kind of golden apples hanging off the tree to just be picked. Okay. So you rank your providers, and then you can, when you get your state fee schedule where you are, or United Healthcare or BCBS, whatever, but workers' comp is the most applicable because that's where a lot of the procedures come from. But you still get a lot of urgent care. So, doing the math, you plug in the reimbursement and multiply by the CPT codes performed by a particular provider, and you can calculate how much more money that provider's worth to you every month. Oh my gosh. How simple is that? And then if you take the top one and the bottom one, the difference is $10,000 a month or $5,000 a month, some huge number per month differential. And if everybody's low, then, well, I guess you got blue sky ahead of you if you can get your medical leadership to get going and get these providers to do the procedures. And if they say they're uncomfortable, that is not a satisfactory excuse. That I would say that that's valid. I'll say it's a valid excuse in a sense that it's true. They are uncomfortable. They're petrified, actually. Okay. So you've got to take measures to have them get their confidence. And the way to get confidence to practice in a laboratory on paid time to learn and do this. And if they can't accomplish that and are not willing to do so, then they shouldn't be at your urgent care. They shouldn't be, because urgent care by definition is illnesses and injuries. Illness is injury, and injuries are procedures. It's not illnesses and referrals for injuries. It's not illnesses and triage injuries. That's not what urgent care is. And we frustrated employers around the country. There's never been a better time to do Occ Med than right now, because they are really, really desperate for good clinics that can do it. Okay. So you rank your providers, put in the monetization of it on the fee schedule, and you'll see where your problem is. And then you could develop a bonus system where let's say you have a variance of, like I said, 70, 75 to 17. And you say, okay, here's what we're going to do. We're going to start bonusing at 60, a score of 60, wherever that number came from. We're just giving that number as it's not 60 CPT codes. It's just 60 as a number, your ranking of 60. So instead of going to the top, which is 75, you go to 60 and say at 60, anyone 60 or above gets an extra check, a separate check for $500 per month. Okay. And then if you reach a numeric of 80, you get 750. And if you reach 100, you get 1,000. I'm just throwing those numbers out. And somebody in your company might say, well, that's a lot of money. And I'm telling you right now, if your company is not willing to do a bonus system of that nature, then you might suffer the consequences of non-viability. I'm dead serious when I say that. You're facing headwinds that are so devastating and so dramatic that you've got to make this investment. And this is, to me, not that much money to do it. It's predictable because you have all the data in your computer already to know what will be the impact of going from an average of 27, let's say average of 37. So the range is 75 to 17, average of 35. How much money, if we raise the mean from 35 to 60, how much money will we gain as a company? And then figure out with your bonus structure, how much money will pay out, and just structure it so you're guaranteed to make money. I mean, it's that simple. This is math. It's actually math 101. And you can do it because you already have the study in place. The data is already there. And so you know exactly what's going to happen with your bonus plan if you're doing it on CPT codes. And you can separate out, because obviously there's a difference on fracture care. CPT codes will be much more revenue than the eye injury CPT codes, and also the laceration CPT codes and the dislocation CPT codes. So you could skew it if you want. You can do any machination you want on these CPT codes, but you really got to do it. And you could do it a different way, RVUs, but RVUs is kind of opaque. I don't really like that as much. I like straight up CPT codes. And it's not illegal. You're paying them to do, you're paying them based on their expertise for performing procedures. And so that if somebody is an RN and they go get their nurse practitioner degree, do they get a raise? Yes, they do. If they're administration and they go and get their MBA, they get a raise. Well, if your provider's going to do procedures, that's a expertise level upgrade of procedures. They should get compensated for that. Okay, next slide. Okay. All right. So that is the overview of what I really want to cover today. The elephant in the room, is the provider performance, and you really, really need to go after it. They are your greatest asset. We love our providers. They're fantastic. They're the best thing ever. They're a great asset, essential asset. But you have to be able to develop a culture of can do, a culture of high performance, a culture of hard work, and not a culture of wimpiness. Okay. You just can't, just wimpiness just isn't right. Okay. That's not what urgent care is. If you want to be that way, then maybe dermatology is the right place to go. But urgent care is rock and roll. I mean, we want to put shoulders back in. We want to put dislocated fingers back in place. We want to put patellas back in place. We want to sew large lacerations. We want to do fingertips, even though they look terrible, like a smashed fingertip. They heal magnificently and wonderfully. If anybody wants help on these procedures, the training of it, how to do it, and Occ One is a fabulous resource for that. It's not the only one, but it's definitely a great resource that if anybody wants to explore that, I'm happy to do that as well and do a Zoom call and show you the website. So with that, any questions?
Thanks, Dr. Kaler. As I said, put your questions in the Q&A. There are a few in there. Most revolve around the CPT code list that you keep mentioning. People are asking about that. And so to get that, can they find that right on your website, Dr. Kaler? Or do they need
No, if they're a subscriber on the website, which some of them I think are, if you're already a subscriber to Occ One, simply go to Quick Check, log in, go to Quick Check, type in CPT, it's all there. I don't have the North Carolina reimbursement in there yet. I'm going to try to get a few other states in there so you can get a panoramic view. I've also reached out to a few other resources on getting average national reimbursement for those CPT codes. That's in the works, but at least finding them out, and then you can check with your billing company and you could figure out what your reimbursements are on your current contracts. But workers' comp is usually based on a state-based fee schedule. Some states don't have state-based fee schedule for work comp. You can charge whatever you want. And so you should be charging robustly for these procedures. Like I think a minimum fee for a procedure should be $100. You just like folks $100 or more. Fracture care, that should be like, 500, 800, 1200 in that ballpark, depending on the fracture. But don't sell yourself out. These orthopods, these referrals we make, it's atrocious. They come in, they sprain their ankle playing soccer or at work, and they have a small avulsion fracture off their distal right fibula, and we put a boot on it. We give them crutches and we send it to ortho. What ortho does, they see the PA over to ortho. They take the boot off, tell the patient, this isn't the right boot. We're going to give you our boot. Wink, wink. Their boot's $1,500. Okay. Then they're going to charge a global fee of $3,000 for that fracture. And then the patient, they bill insurance and they get paid. And the patient doesn't know the difference other than they had to go to two places, which they're frustrated with. But it's atrocious what we give ortho. And that's why ortho urgent cares exist, because we did the referral. We kept sending them garbage, stuff that the orthopods didn't want to take. They couldn't take the OR, right? Because you can't put a K-wire through a little chip fracture. So we refer, like if you have this definition, we refer all fractures ortho. That's suicidal. That's dumb. It makes no sense at all, because some fractures, they heal by themselves with no medical care. You know about that. So if you're worried about liability, that's a spurious excuse not to do fracture care, because the liability in Occ Med fracture care, Occ Med in general, is class 0. Class 10 is neurosurgery. Class 3 is family practice. Occ Med is class 0. The lawsuits are worker comp lawsuits. They're not med mal lawsuits. You don't get sued. I've never been sued. I've treated or proctored 500,000 cases, never been sued. I've done fracture care, tendon repairs, fingertip replantations, you name it, I've done it, never been sued. So, and if you're checking patients in with shortness of breath, chest pain, high fevers, bad headache, you're taking on orders of magnitude more liability than this dinky little injury care here I'm talking about. Next question.
Well, someone's asking about if that CPT code list would be relevant for California or not, or if you have any more insight into the California.
The CPT codes are relevant in every state, period, bar none. Okay, it's national. The codes themselves. Mm-hmm. The reimbursement can be jurisdictional, whether that's state-based, zip code based, really, there's zip codes where you can have limited different reimbursements in different zip codes in certain states. But workers' comp fees, I've never seen one that way for workers' comp. It's always been state based for workers' comp if there's a fee schedule. You might have a fee schedule also like Liberty Mutual, Gallagher Bassett, all these big TPAs, they have these networks, and they might have a fee schedule for that too. But you have to crack the nut. You got to find out once you have the CPT codes, it's real simple to ask them, what do you pay for this? That's a simple question with a simple answer.
Good deal. Someone's requesting that list in the Q&A again, so I'll make sure to send you any of those requests over, Dr. Kaler. You can reach out. We'll give it a minute or two more to see if any more questions pop in. Just want to thank everybody for joining again. Our contact is on screen. I also threw it in the chat. So if you need to reach out to Dr. Kaler or myself, feel free to do so.
I'm surprised there's no questions about providers, about how to deal with a certain provider objection. They'll object based on I'm uncomfortable, object based on medical legal liability issues, object on being too busy in the clinic. And those can all be rectified easily.
Yeah, please, if you have any questions, even if you think it's a step or two away from this exact topic, Dr. Kaler will definitely.
Yeah, any Occ Med question, fine. We can tackle it.
And yes, a few people have asked if this is recorded. It is recorded. We will send out the recording link to everybody that registered as well.
Yeah, and hopefully the sparks won't fly wherever you send it.
Yeah, this can be a sensitive topic for sure. I mean, whenever you're talking about incentives and pay and all that stuff, and so we understand that. But Dr. Kaler's giving away his playbook, right? So use it to your advantage. Don't be scared of it. I'll just encourage you, take the playbook and give it away and do your best and ask some questions if you have them. So it looks like a few have popped in. Regarding productivity, how would you handle providers that do not want to take new injury walk-ins at the end of the day?
Great question. Perennial problem. Because it's policy. So two answers. Okay. One is policy because you promised your community and your employers that you'll be open till 8:00 at night. And if they walk in at 10 minutes till 8, how can you turn them away? That's unethical. It's outrageous. Is that a pain in the rear end? It's a terrible pain in the rear end. And the poor provider they're tired. They want to get home. They want to see their family. They want to put their kids to bed. I get it. That's the nature of urgent care. So they should be glad that you're not seeing someone who calls in and says, hey, I'll be there at 8:15. No, don't come. We're closing at 8. We won't take a new patient after 8. Okay, I'm fine with that. But if they come in 5 till 8, 10 till 8, you have to see them. You cannot turn them away. That's breaching the trust of your published hours. You can't do that. So that would be one answer. If they're getting bonused on CPT codes, I'll guarantee you they'll stay there for that case and they'll get it done quickly. So the second answer is learn to work faster. Because if you view that injury coming in before, near the closing, is that because you're slow that you don't want to, because you're a slow provider? Well, then your answer should not be, I want to send this away. The answer should be, how can I learn how to do these fast? Because I could work wicked fast. I mean, wicked fast. I had PAs that could see 100 patients in 12 hours. Yes, I did. Okay. At a pinch if they had to. Okay. I was seeing 80 patients a day routinely solo in 12 hours for years. That's how I got 500,000 cases. I'm not saying you have to do that. I'm not at all saying you should do that. Oh, by the way, one other caveat too, when someone says that many patients an hour is unsafe, is absolutely untrue. That's a ruse. It's a smokescreen because safety isn't related to how many you're seeing. In fact, it's absolutely proven in the medical literature that when ERs get slower, malpractice cases go up. The reason is people get lazy and cavalier and they're not paying good attention. They get back in the back break room, they're doing other things. they need to work steady, or steady and busy is the right way to go. So I say, now they're starting to talk about, say, 2.5 patients per hour as being the metric. That's insanity. It's got to be 3+, period. 3+. If you go below 3, you can't make money. Can't make money. And if you're that slow, I mean, I can see a sore throat on the clock in 8 minutes. 8 minutes. So that, that's like 6 patients an hour. Okay. Pre-employment physical, that's 5 minutes. So I don't buy it. But anyway, at the end of the shift, what do you say? Well, it's our published hours. We owe it to our communities. We can't be, everyone's talking ethics, morality, truthfulness. Well, here you go. We said we're open till 8. We can see all comers till 8. And if that means you stay over, then you stay over, but learn how to work fast. And I guess as a caveat, I guess conceivably your clinic is slammed. You've got 5 patients waiting to come back. All the rooms are full and someone comes in at 10 to 8, maybe send them away. Okay. Then that's a rare situation in today's non-COVID environment.
All right. You awoken the crowd a little bit. We got a few more popping in. How do you deal with providers that refer to plastic surgery in place of suturing a nose?
Okay. Good question. So there's different types of fractures. Okay. I mean, different types of lacerations, different parts of the body, different cosmetic implications. So depends on how severe the nose laceration is. You said laceration, right? Laceration, right? Yeah.
Yeah. Yep. Nose. Yep.
Okay. So, I would say you can't really push a provider. If it's a really bad nasal laceration, I would say they can refer that to plastic. Okay. They'd simply say, there's a cosmetic issue here. I'm going to refer you to plastic surgery. If the patient then says, oh, no, I'm not going to a plastic surgeon. You're going to suture this right now because that's what I came for. Then you should suture it. Then have sign AMA, or put some kind of caveat there they can sign that. I understand I could have a scar and I was offered plastic surgeon. I declined. I understand that. Sign John Doe. Okay. Do that then. But there's a lot of patients, especially in rural areas, they say, I am not going somewhere else. You're going to do this. I want this done. Farmers, you think you're referring that to a farmer, to plastics? They're not happening. Okay. Show this right now, So, I would say that, yeah, it depends on the severity, and they could take a picture of it with their cell phone, send it to the medical director, and let the medical director decide if it should go to plastics or not. Or maybe if that provider is super uncomfortable refusing to do it, send it to one of your other clinics where there's someone there who can and will do it. So it stays in-house with your company.
All right. Got a client here going, I love the Occ One website. However, my providers don't think that not prescribing 800 ibuprofen to avoid a recordable claim is not right and won't help the patient with the alternative you give. What would you say to them?
I would say, do you have literature to show that combination Tylenol plus an NSAID for routine sprains, strains, and contusions is not highly efficacious and appropriate? If you have literature, I'll listen. You can share that with Dr. Kaler. And if you find it, Dr. Kaler will change the website.
Straightforward. All right. Can you give an example of how to have the sometimes awkward conversation with a provider on the expectation that they treat lacerations, fractures, etc.?
It's in the scope of your license and your practice. Like someone told me once, they said, we should all be practicing the highest level of our licensure. So you would say, it's in your licensure. You had the training. If they say, why did you have the training? Oh, we'll get you that training because it's in your licensure. And we're paying you. You earn that license so that you can practice and be paid what you're paid. You need to practice at your licensure. And we need you to practice your licensure. That's what we promised our communities and our corporate customers. Look at the website. Oh my gosh. I love the website. Fractures, dislocations, eye injuries. I mean, they list all the stuff that they do, but they don't really do it. It's disingenuous. It's wrong. Look at your website. It'll have all that stuff. It's on our website. It's in your licensure. It's on our website. That's what we do. This is what urgent care is. And if you're not comfortable, we'll be happy to arrange supplemental training so that you can do it and you will do it.
All right. If you hear this, might be outside of our specialties, but someone says in Florida, our workers' comp fee schedule is awful. Do you have contracts with the payers instead of accepting the fee schedule? Do you see patients without a formal auth at all? We have several employers that send patients to us without formal auth. We see them if they are established employers with us, but have several not followed through with the auth. How do you handle those patients and employers?
Okay, that's a lot of questions.
Yeah.
I'll start with the authorization. I mean, we would set up an account, and we have an account in our system with the patient they check in with an authorization form, and they check in, and you match the authorization to the company in the computer, print out the work form, and do the medical care because they might need a drug test with their injury. So the way we would handle someone who won't send us an authorization, we won't treat the patient, point one. We will say, if you want to pay by credit card over the phone right now, we'll do that. But if you don't give us the authorization to treat, why would we treat? And how would we expect to be paid if you're not authorized? But we'll take a credit card. And there'll be lots of companies will pay by credit card because they don't want to submit the claim to insurance. And they don't want you to submit it to insurance. Why? Because their premium will go up. And that is not illegal. That's perfectly legit perfectly legit to take any payment. It's not your job to police the employers on what they're doing at their end. Okay. I want to mention something real quick. There was a mention about the ibuprofen and Tylenol isn't the best care for the patient. So because we're connecting it to recordability. So you have to play ball with employers. Okay. To stiff arm them in the face with no proof that ibuprofen and Tylenol together is less care than something else for dinky, sprain, strange contusions. Come on. Then you're not willing to work with companies. You're pushing them in the face. You're rejecting them. And that's not fair. I've always been willing to play ball with employers and learn and understand what their concerns are. And that Occ One is crafted to care for their concerns plus high quality medical care at the same time. It's very doable. And we did it we had $40 million of the annual Occ Med revenue, and it proves it works. And the patients come back and they like us. Okay. And so they get 2 bottles of medication when they come to our clinic. One's Tylenol, one's an NSAID. And that's for the first 2 visits. Visit 3, if they're not getting better, different story. We go to additional care. The first 2 visits, the first 7 to 10 days, come on. There's nothing wrong with Tylenol and ibuprofen to avoid an OSHA recordable. Instead, I'm giving them Ibu 600, which is recordable, or Flexuro, which is a sleeping pill. Okay, back to the authorization. What was the other questions in that? Real long question.
Yeah. Well, the first question as part of that was related to the fee schedule. Do you have contracts with the payers instead of accepting the fee schedule?
Okay, so depending on your state, you can bill whatever you want. So if you have a relationship with an employer and they'll accept your fee schedule, you can bill them and they'll pay you. If they say you have to follow the Florida fee schedule to work with us, then you'll have to decide if you're willing to accept the Florida fee schedule. It's it's a business decision with the employers. And if they say you have to be in, Liberty Mutual's network, then you get Liberty Mutual's fee schedule network and see what that. Sometimes they'll go, fee schedule minus 10% or something like that. But I can tell you that I'm sure these TPAs and the Liberty Mutuals of the world are getting more desperate for better care. So you could probably have some negotiating power there if you say, hey, look, we avoid unnecessary portables, we avoid lost time, our work restrictions make sense, we call the company on every first visit, we avoid ER, avoid unnecessary special referrals, therefore pay us the fee schedule straight with no discount because we're good. Then you should be able to say that.
All right. We have a few more minutes left and a few more questions. So we'll try to get through as many as we can here. Someone's asking for your opinion on if you ever used an internet marketing company when you ran your urgent cares. And if so, how'd that go or which ones?
No, did not. Not saying it's bad, not saying. I just figured out you have to pound. To get Occ Med clients, you have to pound the pavement. You have to make the phone calls and get the meeting. You will not get a client with any mass marketing technique whatsoever. You will never get any traction with Occ Med workers comp with a mass marketing technique. It will never happen. If you invent it, then you should keep it a secret and make millions. But so far, no one's invented it yet. Mass marketing. Urgent care is a bit different. There's these pop-ups, geolocation stuff, which is kind of cool. If they query urgent care and they're near one of your clinic's going to pop right up there and be right there. That's separate from Google reviews. Okay. For Google, the Google search, it's off to the side related to an urgent care query becomes a pop-up, your pop-up. That's kind of the internet for urgent care. I think that would work, but for Occ Med, we never did any mass marketing or internet-based marketing. Heck, there was no internet until like when, the 90s? Mid-90s, I started in 87. I was using a landline phone and sticky notes.
All right. So orders for imaging awaiting auth from work comp carrier or out of control. How do you expedite those?
Okay, so if I have a head injured patient and they need a CT scan, they're getting one. I couldn't care less about authorization. I'll send any patient, anytime, any place I feel there's an urgent need for medical care. Okay. I'll max out my care beyond me. I'm going to get it done. Don't ever let them, if you need a CT for a head injury, you don't wait for authorization, because you'd be in court trying to answer that question about why you didn't get it done because of some authorization issue. That's kind of, don't do that. Okay. Other things like an MRI for low back. Okay. That's classic. Unfortunate, me personally, since the insurance company works for the employer, okay, I would call the company. Hello, hey, I'm seeing Joe. Joe needs an MRI, ordered it. Now they're saying they're waiting for authorization. It's been 3 days. This is unacceptable. Can you light a fire underneath your insurance company to get them to authorize this, if you would, please? That's what I do, and it works every time. I have never, once I get on the phone, I've never been turned down, ever, for anything. So you have to have the company, your client, go to bat for you, which speaks to you doing a really good job in work comp. Because we did such a good job, they was, oh yeah, Dr. Taylor, we'll get on that right away. Because they don't want me upset, because they know I know what I'm doing, and they know that they really need us as a clinic. And Dusty, our next webinar should be on the Big Four. The Big Four: lost time, unnecessary recordables, intuitive common sense work restriction, and first call full goal. Magic. This is my playbook. That's the first page of my playbook. Okay. That Dusty mentioned. If you can do that, they will worship the ground you walk on, and everything else follows from there in terms of being able to have them pay you for your services.
Right. This is a multi-part, and it might need to be our last one depending on time, but the first part of it is, do you see your own follow-ups for fracture management? And if so, how do you code that under urgent care contracts?
Okay. First of all, I do all of the fracture care from beginning to end, of course. It's unbelievably easy. Fractures heal by themselves, right? Just put the right thing on them, okay, what they need, and just re-x-ray them in 7 to 10 days. And then again at, say, 3 weeks, and say, hey, it's all healed. It's good. We're good to go. You're done. 4 weeks, 6 weeks, whatever it might be for the particular fracture. You bill it as a global fee, global CPT code. So when you bill, for example, a distal fibula fracture, there's a CPT code for that, and you get a global fee. And that means you don't get reimbursed for rechecks when there's a global fee, but you do get reimbursed for x-rays. So you're going to do those $75 each for each visit. And the recheck visits are very easy, but you've already received $500 to $1,200 for the fracture global fee.
Do you have someone asking about, if there's any training out there that you're aware of to help fill out the workers' comp form? It's a specific form they're mentioning. Do you know of any resources out there to help?
Those are state-based. So I don't know, other than, it'd be whatever the form is that your state requires, if any. Assume there is, since you mentioned it. But I don't know. I don't know whatever would be hard about that. But filling out this form is filling out a form. So don't have any magic on that.
Yep. All right. We are going to have to end it there. We are running out of time here, but as Dr. Taylor mentioned, we will definitely do more of these, potentially on his Big Four playbook next. But if you have any other topics or ideas on that, please send those our way too. We love ideas and what you want to learn about, and we'll do our best to accommodate. Otherwise, again, thanks for joining. Record our contact information and reach out if you have any questions. Thanks, everybody.
Take care. See you.